Thank you for being here. So let's get started with the BT symposium. We are very honored to be here with such EP rock stars. So thank you very much for being here. So let's get started, and we are going to start with Dr. Roderick Tong. Dr. Roderick Tong needs no introduction, and we are very happy to have you in Mexico City as always. Thank you very much for being here, Dr. Tong. Thank you.
Well, thank you very much, and I'm really delighted to be part of this session. And my job is to set the table and discuss what do you need to know before you think about VT ablation. And much of this is also why do we do VT ablation in the first place? These are my disclosures. I will present a clinical scenario of a 62-year-old woman that I saw at the University of Chicago who was only 3 weeks after an ST elevation MI. And when I was talking to her, she went into VT and had a very rapid monomorphic VT. The ejection fraction is 40%. So this is a very complicated scenario because guidelines do not really inform us of when to do a VT ablation in this situation where the ejection fraction is 40%. Do we do an ICD? Do they get antiarrhythmic therapy? Do they get ICD with antiarrhythmic? Do they get ablation only? Ablation without ICD, with ICD? And the answer is we don't always know everything in terms of every clinical scenario. And I want to remind the audience that in the AVID study, which was the only study to look at secondary prevention, remember there were 2 negativo studies. SIDS and CASH were negative in secondary prevention. You have the ejection fraction of over 35 was no benefit to defibrillator. So I do think that in the era of guideline-directed medical therapy, there may be a greater role than ablation. I also want to remind the audience that amiodarone works. This was the OPTIC trial that showed that the recurrence of ventricular tachycardia is only 10% in patients that get treated with amiodarone and beta blockers. So amiodarone does work, but we think it doesn't because many of the patients that are referred to us are already amiodarone refractory. So there is a recall bias and a referral bias for those that do not receive amiodarone success. And we know amiodarone has many potential side effects: 1% optic neuritis, 5% hepatotoxicity, up to 15% hepatotoxicity, and then there's the 3% of irreversible pulmonary damage. If we had patients sign a consent form for amiodarone, nobody would sign it. Nobody would sign a consent form for amiodarone, but we have to do it for procedures, but not so much for medications. And it's also important to understand that almost 1 out of 5 patients cannot continue taking amiodarone because of side effects. So these are the things to think about anytime you deal with a VT patient. Amiodarone also, in a prospective randomized trial called SCUD-HEFT, showed that it increased mortality beyond control. So amiodarone is associated with increased death in patients with New York Heart Association Class 3 in both ischemic and non-ischemic. So our goal of VT ablation for me is so patients do not need to take amiodarone. That is my number one. But the other reasons that are more popular is because to reduce the incidence of sudden death and then minimize ICD therapies, which we know are major problems. Now, when you get a defibrillator, everyone is happy that you have protection. But when you receive shocks from the defibrillator, your risk for mortality increases by 3 to 5-fold. And this was very nicely demonstrated in SCUD-HEFT. And it's very clear that patients that get shocks are anxious, they are depressed, they are afraid to go outside, called agoraphobia. And this depression is actually associated with increased mortality. In a very small series of those that had depression versus no depression and PTSD, that actually is independently associated with higher risks of mortality. So we know that that shocks are associated with increased mortality. We know that VT ablation decreases the risk of subsequent shocks. So shouldn't VT ablation reduce mortality? The hypothesis is it should. it absolutely should reduce mortality. And one way to look at this would be a large randomized trial, and the other way would be to retrospectively to look back at successful VT ablation. So we put together the largest series of VT ablation called the IVTCC, the International VT Center Collaboration, and we looked at patients that did not have VT after ablation and those that continued to have VT. It was very significant that there was a reduction in transplant-free survival if you did not have VT after ablation. Now, the problem with this 2,061 patient study is that there was no randomization. And it's possible that the people that have more VT have other commingling confounders that actually increase their risk for death as well. But if you are to look at these data in New York 1, New York 2, it's still significant within New York Heart Association Class 1 between those that have recurrence and those that do not, as well as New York Class 2. It is further significant in New York 3 as New York 4, because much of the criticism may say the sicker patients have higher risk for VT and heart failure. But here you can see that the patients with New York Heart Association Class 4 that do not have VT, their survival rate is better than a New York Heart Association Class 3 that continues to have VT. And the New York 3 that does not have VT after ablation has a better survival rate than a New York Heart Association Class 2 that continues to have VT. And the last is the New York Heart Association Class 2 that doesn't have VT appears to do better than the New York Heart Association Class 1 that has VT. So VT itself almost increases you one New York Heart Association class in terms of survival, which is very important. So these data were very relevant and significant across a very large data set. The problem, it was non-randomized data, and that's where our limitation is. Multiple studies like SMASH and VTAC have shown us that depending on the group, there is significant difference between ablation and control, but VTAC was done in Germany with a more limited ablation strategy, and SMASH was done in the Czech Republic mostly by really a single operator. And those success rates with SMASH have never been replicated, 88%. But it's still important that compared to control, these are significantly improved, and this is why we do ablation, to reduce recurrent VT. And the VANISH trial was the largest VT ablation trial ever performed in ischemic cardiomyopathy patients, and showed that the composite endpoint of storm, shocks, and mortality was decreased compared to antiarrhythmic therapy. So it's very clear why we do VT ablation. It's also clear that maybe the earlier you get someone, the better you do. So that's why early referral for those that are in the audience that don't always do VT ablation, it's better to send them to centers that do VT ablation, because in this paper from UPenn by Dave Frankel showed that earlier referrals associated with better outcome. And this was also true in Germany by Borislav Dynov and Gerhard Hendrick's group, that early referrals tended to have better outcomes. So that is definitely a trend. The latest referral is the VT STORM patient, and STORM has the highest risk of mortality. They have a higher risk of mortality, of inpatient mortality, of VT recurrence, but even in STORM patients in the IVTCC, there is a significant improvement in survival after successful ablation. So I think the data is quite clear, which justifies why in 2006, we were waiting for patients to get multiple shocks before thinking about ablation. And in 2019, you can see there's two indications, which is that even a single episode of VT should even be consideration for ablation. So I think that that is where we have moved to try to ablate VT during the calm before the storm. And that is a very important paradigm shift for VT ablation. We conducted a study across Asia, which was the first ever Pan-Asia study that was the first to include non-ischemic cardiomyopathy, which is very important. It's the first to use ultra-high density mapping for all, encourage epicardial, and we even had a registry. This was a trial to do ablation during the same hospitalization as the ICD implantation, which is why it is concurrent with defibrillator therapy. And we had a third of the patients ischemic, a third ARVC, which is very common in Asia, and a third non-ischemic. And what was very important is that we were able to demonstrate that the composite endpoint was significantly reduced with early ablation and the same setting as the defibrillator. And in America, most times people do not practice this way. If you come in with VT, you get a defibrillator, you go home. If you get shocks, then you come back for ablation. This is different. This is doing the ablation in the same setting. And the Partita trial was the most positive but controversial study that just came out by Paolo Della Bella, showing that early ablation was associated with improvement in mortality. And what they were able to find was that the patients that did not get ablation, there were 8 deaths, and the patients that were ablated had 0. And the only reason people think that this could have been an error in randomization was because the cause of death was sepsis, unknown, squamous cell cancer, sarcoma, and they were usually not related to VT, which is why this is still confusing. So a meta-analysis was put together with every VT ablation trial, and it shows that it's very obvious that there is a reduction in ICD shocks across all of the studies, as well as hospitalization. There is only one study that shows mortality benefit, which is Partita, which is a far outlier, which is the last one, and there's no compelling evidence that VT ablation reduces mortality yet. I do believe that VT ablation reduces mortality. There is no question in my mind. And before I die, I would like to prove that one day, but we must learn from our heart failure colleagues. How many patients were needed to demonstrate mortality benefit from Entresto, the ARNIs, right? The angiotensin neprilysin inhibitors? Well, they are very smart when they do trials. They have 20% that exit the study because they don't tolerate the drug. So it's very highly selected with the heart failure population. And the absolute reduction in mortality demonstrated with these patients are 3 to 5 year studies, and all the VT ablations are 1 to 3 years, pause being the longest. The difference is only 5% with a number needed to treat of 20. And this is GDMT, this is standard treatment. So we might need 8,000 patients, 5 years to be able to demonstrate these differences, because that's what's needed in heart failure for these patients. The last thing I will comment is how do we assess risk and how do you improve success before you do your ablation? Well, there's always the risk that someone may die on the table, which is hemodynamic compensation, and we'll talk about the pain score. We like to use lactate as a very primitive marker. If the lactate is elevated before ablation, you're going to have some problems. So you don't want to take patients in with elevated lactate, and we always have the heart failure team watch these patients, maybe do a right heart catheterization and diuresis before. We'll talk a little about imaging and then some intraprocedural tips and techniques. The PAINS D score was introduced by UPenn, by Pasquale Santangeli, with pulmonary disease, age, ischemic cardiomyopathy, New York Heart Association, EF, and STORM. These are pretty obvious, but I think the use of anesthesia and pulmonary disease is less obvious. Anesthesia is a choice, but pulmonary disease is very important, and I think part of it is these patients have less ability to compensate for respiratory and metabolic acidosis when they have COPD. And diabetes was also a risk, and they showed that patients with high pain score versus low pain score was very good differentiation for acute hemodynamic decompensation. So always think about the patients with this, and I was actually the reviewer on this in 2015, and this has come a long way for risk stratification. The problem is there's still 5% of patients that die in the first month after VT ablation. There's 5% of patients that die within the first 31 days, and this was work done by Pasquale Santangeli from IVTCC. And if you look at the major risk predictors, it is chronic kidney disease, ejection fraction, the prevalence or the presence of an untolerated VT, and the evidence of electrical storm. So this is important to understand. How do we reduce early mortality after? And there are still important significant adverse effects with VT ablation. And this was just a study done that was led by David Katz, the Colorado group, showing that there's still an 8% risk of complications. We always tell people maybe 1 to 2% risk of complications, but the real world data suggests that it may be a lot higher. So maybe we need to change how we do the consents. This is also new data about brain emboli to consider, and it is likely that with any manipulation within the ventricle and ablation that you can get new asymptomatic cerebral emboli. And the real question is, how do we prevent this? Greg Marcus did a transeptal versus retrograde approach, And we believe that transeptal is probably the best way to minimize aortic arch atheroma and emboli, and that's very important. The last thing I will talk about is the non-ischemic cardiomyopathy patient pre-procedurally. We recognize that class D is not going to benefit from endocardial ablation because the scar is mostly in the epicardium. And the seminal work from the Penn group showed that there are more late potentials and more substrate in the epicardium than the endocardium in the infralateral non-ischemic subtype. And Katja Zeppenfeld has really shown anteroseptal versus infralateral as a great way of separating non-ischemic cardiomyopathy with the understanding that anteroseptal does not require epicardial ablation. But 15 years ago, we were doing epicardial for every non-ischemic cardiomyopathy at UCLA, so this has been a very important shift. The outcomes in non-ischemic are not as good as they are for ischemic because the substrate is variable. And the worst are maybe sarcoidosis and valvular disease and hypertrophic cardiomyopathy. The post-viral myocarditis is the best one. And genetics has been the one thing that I believe has changed in my practice the most in the last 5 years. The genetics of non-ischemic cardiomyopathy are very real, and Zeppenfeld has shown that 40% of patients may have a positive genetic test, and this could be lamin AC, and in this patient with a left bunduloid VT, poor aria progression, this patient that we dealt with had mid-myocardial scar, septal, and this was titan. So there's many patients that we're identifying with lamin and titan, and why do you need to know that before doing the ablation? Well, because understanding the MRI first tells you that if the scar is in the septum, we don't need an epicardial approach. We also need to understand that there's going to be a lot more VTs in large septal scars, and that can be very confusing and frustrating. But more importantly, the prognosis of patients with full-length septal scar in our small series from University of Chicago was only 20% success rate at 1 year. This is the lowest success rate I've ever published, but I believe it is honest and I think it is real. It is palliative for these patients with lamin, titan, with full-length septal MRI. So prognostication is important because I cannot tell this patient there is a 50 to 80% chance of success with this ablation. We send these patients over to heart failure for earlier transplant and LVAD consideration, and we tell them that ablation is more palliative because this is a patient that we were not successful in. And this is a patient that got heart transplant, and we rushed to go get it. And you can see that the ablation technology is not sufficiente to be able to penetrate transmurally. It's not enough, and we need newer strategies to be able to get these septal substrates. So in summary, ladies and gentlemen, the goal of VT ablation is clearly to improve quality of life, reduce shocks. We cannot say we save lives with VT ablation yet. I do believe we do, but we do not have adequately powered studies to show that. And I think we need to learn from our heart failure doctors. Earlier referral is always going to be better to ablate someone before storm than after storm, and the risk and the substrate assessment prior to the ablation will likely improve your success and the ability to have shared decision-making with the patient. Thank you very much.
Thank you, Rod. A great talk, as always. And the second hot shot we have now with us is Dr. Luis Carlos Sainz, who is a cardiologist and electrophysiologist from Colombia, from Bogotá, Colombia, and is international director of the Cardioinfantil Arritmia Center in Bogotá.
Good afternoon. Thank you very much for the presentation. As you know, LV Summit is the highest portion of the left ventricular epicardium that is delimited by the LID, the circumflex, and also by the first perforator that is delimiting the base of the LV Summit. LV Summit is transected by the great cardiac vein and the AAV, like you can see here, and divides the LV Summit in two aspects, the anteromedial or anteroseptal aspect and the posterolateral aspect. So LV Summit is a very complex structure because it's surrounded by very important anatomic structures. So Such, the LV summit is a high structure placed at the left side of the midline. So in that way, the EKG morphology that we can expect from these arrhythmias is inferior right X directed, and as is posterior to the septal RVOT, the transition is earlier than RVOT arrhythmias. The morphology could be left branch block or right bundle branch block, depending of if the arrhythmia is coming from the septal aspect or from the lateral, as you can see in the slide. But it's important also to remind that by definition, the LV summit is an epicardial arrhythmia. So you can see prominent pseudo-delta generally in these arrhythmias. You can recognize the anatomy of the LV summit and the anatomic relation with the surrounded structures by eyes. Eyes is key tool to deal with these arrhythmias. For mapping and ablation, you can see a transversal cut-off view of the summit, and you can see here a longitudinal view of the summit. You can see the left pulmonary cusp here, right? The left cusp of the aortic valve and the subaortic portion here. Okay, so it is important to keep in mind during mapping of LV summit arrhythmia that LV summit could be the origin of epicardial arrhythmias, but also the breakthrough from intramural sources. And in relation with the anatomic constraints for direct mapping and ablation of LV summit, usually we have to find the site of origin and to ablate from the adjacent structures to the LV summit. So the structure allowing us simultaneous mapping of both portions of the LV summit and also the intramural space is the AIV and the great cardiac vein. Okay, so the usual strategy for mapping and ablation of LV summit arrhythmias is like in any other PVC. It's proposed by EKG analysis to predict the site of origin, ice the anatomy, sequential map from the adjacent structures, and ablate from the earliest activation spot that usually is the best pace mapping also and the QS unipolar morphology. If unsuccessful, you have to ablate from the earliest aspects of the surrounded structures. But I'm gonna show you the limitations of this approach. So you can see a case from our practice in which we mapped this arrhythmia. So the early activation in the RVOT was minus 30 milliseconds and was focal activity, as you see. Pace mapping was very good, and we ablate unsuccessfully. And why? Why that happened? Because we are early, we are with QS morphology and unipolar, good pace mapping. So if we analyze more carefully the local EGM, we can see that the earliest portion of the electrogram was a real far field signal, right? So the near field signals could be here, meaning that is late. The true activation is late, explaining why we fail. And that implies that we have to analyze carefully the signal, the local signal, to differentiate when we are dealing with a subendocardial arrhythmia or maybe arrhythmia coming from the other side or intramurally. You can see here a case in which the onset of the bipolar electrogram is almost coincident with the max DVDT, negative DVDT, meaning that you are almost on top of the source. So that predicts that you are going to be successful during ablation. The problem is when you have these kind of electrograms in which the onset of the bipolar is, and the interval from that onset to the maximum DVDT is longer, right? Because that means that you are not on top of the source, and your probability or chances for fail increase a lot. So that was confirmed by some animal research in which if we pace from here and you record from different electrodes in the epicardial surface of the animal, and you will have these kind of electrograms a Q wave in unipolar electrogram when you are recording on top of the pacing site. That is the site of origin of the activation. But progressively, as longer as the distance, you can see a wider R wave. So this is good to differentiate if you are on top or far away from the source, but just for subendocardial sources, arrhythmias. But when you are dealing with intramural arrhythmias, you cannot apply this analysis. Why? You can see here in the same animal experiment how the activation was recorded from A. From the same electrode, a pacing was performed progressively deeper. So you can see a QS morphology in the unipolar when you are recording on top of the pacing site. So you are recording subendocardially. But if you move deeper and deeper and deeper, you still have QS unipolar morphology, right? That progressively is shallower the onset of the unipolar EGM, and with this kind of inscription. So that means that having a QS morphology not always assure you success, not always assure that you are on top of the source. So you have to carefully analyze the EGMs to understand that, okay, to plan your procedure. So in this case, we went to the opposite side, so you can see the activation, subaortic activation here below the junction, in which we record a late electrogram. Still QS morphology, but for some reason we decided to ablate there successfully. So how to explain why we ablate successfully despite of being late, and we didn't ablate successfully at the RVOT that was earlier one with good pace mapping? Well, we can explain that by preferential conduction concept. You can see here tractography of the architecture of the fibers at the level of the septum. You can see a transversal cut, and this is the opposite direction cut, but you can see how the direction of the fibers is totally opposite. Change very, very, very high change at this level. So you can see the intramural fibers, and you can see at subendocardial, the left ventricle and right ventricle, how the fibers is in the opposite direction. So we know that when the conduction travels in the opposite direction to the direction of the fibers, the conduction could be slower than conduction along the direction of the fibers. That could explain why you can have similar activation in the RVOT and the summit, despite of RVOT is a longer distance, right? So this is very important concept also. Hypothetically, you can have many different patterns of preferential conduction that happens in the subendocardial and the subepicardial, transmurally, etc. So you can see here, this pattern could be explained our case, because in this case, the source was subepicardial at the LV ostium, at the aortic portion of the LV ostium, and we ablate below the cusp despite of being late. And why? Because the activation probably was traveling far away from the subaortic portion, explaining why this here was late, here was late, sorry, because there wasn't transmural activation, and we ablate successfully. But sometimes we ablate at exactly the same spot without success. Why? Because in those cases we can have a source at a longer distance to the subaortic portion, but the conduction could be transmural here preferentially, in comparison when conduction just in front, below the source. So if we ablate here, we are going to have a failed procedure. So important concept. So this is another case from our practice in which we mapped this arrhythmia. We found the earliest activation inside the coronary sinus. As you can see here, minus 20 milliseconds, QS, excellent pace mapping, etc. So we decided to ablate just in front, just below, in the subendocardial aspect, just in front. We ablate hard, 3 minutes ablation, 40 watts, 20 to 30 grams, etc., without success. So finally, we decided to ablate inside the coronary sinus in the earliest spot. We ablate at 10 to 20 watts, 10 to 30 grams, 10 seconds until completing 1 minute to eliminate the arrhythmia. So we ablate successfully, acute success, but the problem is after 1 month of follow-up, the patient present recurrence of the same arrhythmia. Why that happen? Why? We have to remind that when we are ablating at front or after failed ablation from adjacent structures, and we need to ablate inside the coronaries, the great cardiac vein, this is a risk factor predicting failed procedure, predicting recurrences after the procedure. And why? Because obviously we have a lot of limitations to ablate there, high impedance, high contact force, the coronaries could be near, etc. So you can see here how the fat tissue could be in between the vein and the summit. So trying to isolate the summit from ablation. This is a series showing when you ablate inside the great cardiac vein, even you are earlier than 20 milliseconds, you fail in half of those patients. Okay, this is our case then. So this is the venography at the first case, and this is the venography at the second, at the redo case. And you can see how we ablate, but we occluded the AIV. This is the level of the first perforator. You can see here almost the same PVC after recurrency. So by fortune of us, the first perforator was still open. So we could advance, you can compare both venographies, and we advanced a wire, and we recorded even earlier activation when compared with the activation at the same procedure, and the previous procedure, sorry, in the coronary sinus there. So we instillate alcohol, and we eliminate with durable effect the arrhythmia. You can see the kind of lesion after alcohol. You can see here the lesion. Okay, so we published this case as a part of a series that also published Miguel Valderrabano, in which 15 patients underwent alcoholization after failed ablation from the RVOT, LVOT, coronary sinus, etc., etc. So in those cases, despite of early activation was recorded, good pace mapping, etc., when mapping was performed through a wire inside the intramural space, through the first perforator, always we recorded at the earliest activation, meaning that the true origin of those arrhythmias were intramural. So you can see these kind of maps that are so frequent when dealing with LV summit arrhythmias, focal activation in the RVOT, focal activation in the coronaries, in the great cardiac vein, in the junction with the AAV, always near to the first perforator. For some reason, maybe it's preferential conduction related with anatomy, the coronary fat, etc. But that means not much. We have to map inside, okay? So this is another case from our practice in which a patient presented with two frequent PVC morphologies, left bundle branch block, right bundle branch block, that appear intermittently during the same procedure and very frequent. This is the map of the left bundle branch block morphology, earliest focal, minus 30 milliseconds, minus 19, 12, excellent pace mapping from there. And this is the map of the right bundle branch block morphology. So it was earlier in between the left coronary cusp of the mitral valve. But the earliest activation was far field also, okay? So we decided to ablate there, just in front of the left cusp, and we eliminate both morphologies. That obviously suggests that it was an intramural foci, maybe, but with two ways of preferential conduction, explaining that one way, the exit of one way was septal and the other was lateral. Okay, so this is the reason why I totally agree with the approach proposed by Fermi, that maybe it's good for every single case to map the epicardium through this multipolar catheter, and at the same time trying to map the intramural space through a wire, etc., to decide if it's intramural or not. This is very important because when you find the real site of origin and you ablate on top or closer, your success rate could be higher and less recurrency after follow-up. A difference when you are ablating just the breakthrough sites, your success rate, acute success rate is 67%, and the recurrency rate is almost 30%. Okay, this is what we are doing recently. We included the sequential map from the left cusp. You can see here the activation of this PVC morphology from the RBOT. Again, same focal activation, relatively early, good pace mapping, etc. And when we advance a wire through the annular vein here, we record even earlier activation. So you can see here the tip of the wire on the carton map is here. So we took advantage of the left pulmonary cusp because it was just on top. Okay, and we ablate from there. You can see here the activation is very early. You can see this tiny signal that is early. The pace map there was almost perfect, and we ablate from there, and we eliminate the arrhythmia. So that is another adjacent structure that can help you to understand the activation. Okay, to end, I have to say that sometimes you have to use payload approaches like high power, half normal saline, bipolar ablation, etc. But it is important to keep in mind that if you are going to use these aggressive approaches, you have to understand where is your site of origin. Because if you just ablate the breakthrough zones, you fail, but actually with a high cost sometimes. So you can see the kind of complications reported that is increasing. The reports after LV summit ablation by aggressive approaches, you can see pseudoaneurysm. You can see this pseudoaneurysm, for example, very difficult to treat, to close, okay? You can see, this is from our practice, this is a VSD after ablation from both sides, okay? You can see the image by eyes. It's a restrictive VSD, so the patient is in follow-up. But remember that the risk factors to get these complications are always stim pops, audible or not audible. Stim pops associated with high power, prolonged duration application, high contact force, aggressive ablation from both sides to deal with intramural. So we have to learn how to predict, how to detect, how to prevent stim pops. This is the key point. During regular application of radiofrequency and also during more aggressive approach. Okay, those are my take-home message. Please read. Thank you.
Thank you. Thank you very much, Luis Carlos Sainz. It was a wonderful lecture. Thank you. Thank you very much. So our next speaker needs no introduction too. Is Dr. Andrea Nata. So Dr. Andrea Nata is the head of the Texas Cardiac Arrhythmia Institute. So we are very, very pleased to have you here. Thank you. Thank you very much.
Thank you. My goal is to convince you about doing something different in ischemic cardiomyopathy than what we've been doing. So I think Rod already mentioned this. I think one of the reasons why it's important to do the best we can to achieve a good outcome, and I will talk about what that means, is because that can impact patient survival. This is actually, Rod was the first author of this, come from the international registry, showing that regardless of the New York Class Association and ejection fraction, a successful ablation has an impact on survival in this patient. Recently, the Partita trial also shows some mortality benefit, although this is a small number of patients and certainly need to be, as Rod mentioned, need to be supported by a larger study. Other study clearly showed recently that in ischemic cardiomyopathy, ablation is better than drugs. And we'll talk a little bit about how important it is to try to actually discontinue drug after a successful ablation. And this is from Spain. And this is another study that Rod Recently, probably was a multi-center done in Asia, again showing ablation being more effective than the medical therapy. And this is a meta-analysis in ischemic cardiomyopathy, again showing the benefit of ablation. So let's go back to our patient on the table. So what is your goal with ablation? It's just freedom from any VT, just eliminating non-usability, and we'll talk a little bit about that. The real goal, I think, today, with the way we do the procedure, is actually to be able to make the patient free from recurrence of any VT off antiarrhythmic drugs. There is very good data. I think I don't know if you were in this morning in the session on AFib, but also in AFib there is good data that drugs increase mortality, but in the heart failure literature, you actually have very strong data suggesting that amiodarone is an independent predictor of mortality. So the ability to discontinue amiodarone, which is really the drug of choice in this patient, is important. So for many years, and still today, we drive ablation by induction and mapping. I think we realize two things, that although can be effective for the arrhythmia that you can induce and sustain, is probably not the best option. And this was clear from this study that led to approval in US of open irrigation, showing that at 6 months, more than 50% of the patient had recurrence with this approach. Not only a recurrence, but the vast majority were still on antiarrhythmic drugs. So clearly, you have an impact on patients, because if you look at ICD shock, there is a huge reduction, but when you look at actually recurrence of VT, then it's a completely different situation. So what are the issues that we're dealing with? One is hemodynamic instability of many of these VT. There is a small number that can be up to 10% that are totally non-inducible, and clearly, program stimulation is an unreliable tool, especially the way we are performing from here, from the right ventricle. And also, we have to remember that pretty much most of our patients come to the lab loaded with drugs, which has impact on our ability to show any possible reentrant circuit that the scar can sustain. One thing that sort of prompted us to do something different is sort of looking at what was done in the past. This is actually from the surgical literature, Dr. Josephson. Although in the operating theater they used to induce, map, look at the early site, at the end the strongest predictor of success was elimination of all the scar that the patient had. Obviously, with a surgical procedure that was associated with high mortality rate, but whoever survived actually did very well when the scar was removed. This sort of substrate-based approach is what we do today. Our group, and I'll show you some of the initial data, call this scar homogenization. Every center sort of use a different name. You see here the channeling, ripple mapping, core isolation, substrate isolation. You call it the way you want. The idea is that we all recognize that a substrate-based approach doesn't rely necessarily on induction, and mapping is a better strategy. This was the first paper that we published as a non-randomized study where we have two groups. We actually selected patients that did not have history of cardiac surgery to encourage the operator to also do an endoepicardial approach, which was done in about 30% of the patients in this series. And when you look at the success rate, the freedom from any VT, a follow-up was much better in the homogenization group. Not only that, if you look at the chances of discontinuing antiarrhythmic drug, there was a huge difference, which I said this, that's a very important additional benefit of a substrate-based approach. This study was followed by a randomized series, multi-center, where actually we selected patients where you think that mapping the conventional way would be enough, because those are people that show up in stable VT, So you would think, we can just map and ablate and that will be enough. But when you compare again the induction and mapping approach versus the substrate was again more successful. And again, even in this series, it was associated with a higher likelihood of discontinuing antiarrhythmic drugs. So now, so that kind of brings to the next question: is inducibility really relevant and reliable in this group of patients? So I'll show you this example, and then I'll show you a series that we recently published. This is a patient with ischemic cardiomyopathy that came to the lab on amiodarone and lidocaine, as many do. And this is the endocardial scar, a large anteroseptal. We did homogenization, and then the patient became non-inducible. So we decided to still go and look epicardially, and despite the patient now is non-inducible, there is still a significant amount of epicardial scar that you see on the right side of the screen. So this patient was part of this series. This is a large series of 361 patients with ischemic cardiomyopathy. They were ablated in our institution. The majority of them underwent endocardial ablation only. And then a group of consecutive patients towards the end went epicardial ablation despite they were non-inducible after the endocardial homogenization. And a 5-year follow-up, there was a much better outcome in the group than the endo-epicardial approach. Again, with a higher chance of being off drug. If you see here, the patient in group 1 had a much lower number, only 45% still on antiarrhythmic drug versus 89% in the group that had the endocardial ablation only. So huge difference of discontinuation of antiarrhythmic drugs. Is this unusual? I think Rod mentioned this. Is actually from the UCLA group, showing again a higher success rate long-term with the endoepicardial approach. This is a series from Spain, again showing much better result with the endoepicardial ablation in ischemic cardiomyopathy than the group with endocardial approach only. And this is a series where they have 3 groups. One that endocardial approach only with the and one endo-epi, and then there is a group that endo only despite the transmural MI based on MRI, and the group with the transmural MI that endocardial ablation only had the poorest outcome. So MRI could be a way to decide if you want to be more selective, although I have to say in our series, those who were consecutive patients that were non-inducible, no imaging, and all of them had epicardial substrate. So, but that could be sort of an option to consider if you want to be more selective. This is another case that eventually in their 3rd procedure underwent epicardial ablation after 2 failed endocardial. This is another series from Brazil, again showing higher benefit with endo-epi in the ischemic group as compared to the endocardial approach only. So, and this is our initial series with the radio ablation. If you look at this, 4 of the 5 patients here had ischemic cardiomyopathy, they have history of CABG, and had at least 2 endocardial homogenization in our lab. So we know there was no endocardial substrate anymore. And all of them, after the endocardial homogenization, were non-inducible, and all of them a recurrence between a few months to a maximum of 6 months. Clear, again, sort of suggesting that with an endocardial homogenization, you can affect inducibility of a more epicardial substrate, but it's still not enough long-term in this patient. This is actually a meta-analysis showing that when you actually do a good job with addressing the all substrate, not just the endocardium, actually this can impact even on all-cause mortality when you put all the study together. So I'll stop here saying that catheter ablation of VT in ischemic heart disease reduce the risk of VT recurrence, storm, ICD therapy, and ICD shock. But endoepicardial scar homogenization was associated with a significant reduction in VT recurrence and a lower need of antiarrhythmic drugs long term. So a combined endo-epi ablation reduced the risk of all-cause mortality in patients with scar-related VT when you look at all studies together. And in patients with transmural MI, the combined endo-epicardial approach is certainly recommended as a first-line therapy. Thank you very much. And this is my last slide. So we have published this data already a year ago. I hope for you to accept that it's going to take less time than what happened to the person that you see in this picture. Thank you.
Thank you very much, Andrea. It's a great pleasure to have you here in Mexico. And we continue with another hot shot. Is well known what everyone is, Fermín García. Dr. Fermín García is cardiologist and electrophysiologist of the Hospital, the University of Pennsylvania, USA, and a new honorary member of Lahrs. Thank you to accept the invitation. Fermín, thank you very much.
That's a hot shot, but I like it, huh? I'm going to believe it. Okay. So my role is to describe epicardial mapping, and really in the setting of initially non-ischemic cardiomyopathy, because that's where the story comes from. And I want to define what I'm going to be talking about. And I'm going to be talking about those patients with VT that have normal coronaries, or that have coronaries with disease that does not fit the scar distribution, or has some coronary disease, but the disease is out of proportion to the cardiomyopathy. Now I'm going to convince you that the most important tool in VT ablation is a 12-lead EKG of the clinical VT. Because if you have a patient with AV-NRT and then you find you have an accessory pathway and you ablate the accessory pathway, the patient is still going to have AV-NRT. So I think knowing how the VT looks is very, very important. I think we need to understand the disease of the patient before we take them to the EP lab. And we need to go to this story. And the story that created epicardial VT was the story of an arrhythmia that did not fit the substrate. So we need to find tools to prepare before we go for the VT ablation. So when we go to the lab, just like Osorio shows his workflow on AFib, I think we should have a workflow for VT. We need to get prepared to the lab to make this an effective, fast, short, safe procedure and not a 10-hour procedure with multiple inductions. And then sometimes we don't have an identifiable substrate, and we're going to have to figure that also because the patient is having VT. And then just Andrea showed that you can ablate the substrate and don't look at the VT, but I think we're still electrophysiologists, and we need to combine both. We need to understand the VT and the substrate and not try to define everybody as one or the other. And I'm going to discuss some of the tools and techniques to do that. So similar to what Luis showed for PVC, we have a workflow and an algorithm for VT. And you can apply this to ischemic and non-ischemic cardiomyopathy. And the first most important thing is to understand the 12-lead EKG. And then you need to have some sort of imaging to find a substrate. It could be an echo, it could be a CAT scan, it could be an MRI, it could be whatever you want, but you need to try to have a hypothesis of what is the disease process right here. And then, of course, you might decide to start in the endocardium because the endocardium is the easy way to start. But particularly when we fail, we need to think what's happening. And this is the story of the VT has to be thought as a myocardial disease with 3 dimensions and not everything is endocardial. So I'm going to do some simple teaching points that I want you to take out home after my talk. This is a patient that had an RCA infarction. and he underwent 2 very good center prior VT ablations with substrate modification, non-induction. This area was burned to no electrograms. However, the patient keeps having VT. And this is someone who never had a recorded VT. This is someone who never had an attempt to induce VT, either before or after the procedure. And the procedure was based on substrate modification. Well, the first thing I did when I saw this patient was look at intracardiac echo, and I kind of knew what was going on. But really, what defined the problem here was this. This is the VT inducted in this patient. When you look at this VT, this is a left bundle VT with late transition, positive in one and superior axis. So if you understand electrocardiography, you know that this 12 lead EKG doesn't belong to this scar. And you can burn the heck out of the substrate as many times as you want, and you have VT still, because the VT doesn't fit the substrate. Because this patient has an RV infarction. So if you don't fit the VT and the substrate to the patient, there's no technique, there's no endo, there's no epi, there's nothing that you will be successful. So to say to me that we don't look at the 12 lead EKG, we're electrophysiologists. This has to be part of the procedure. So the first point message is you need to understand the electrocardiogram of the VT, if it's available. If it's not available, I think you have ways to try to induce it. But the bottom line is the EKG has to fit the substrate of the patient. Otherwise, we don't have a target. We need to define the target of the clinical arrhythmia. Because the VT substrate is very complex. This is a very beautiful slide by my colleague Wendy Su in Colorado. And the post-MI VT, why do endocardial works? Because most of the time it's subendocardial. The problem is that in non-ischemic cardiomyopathy patients particularly, and this of course can be applied to certain patients with ischemic cardiomyopathy, you have disease on the endo, then you have a different level of disease intramurally, and then you have a different disease in the epi, and all are layered. They're not at the same level necessarily. So this becomes a very complex arrhythmia substrate. So point number 2, ischemic cardiomyopathy and non-ischemic cardiomyopathy are completely different substrates. And you need to learn how to identify the substrate before you get to the EP lab. And you need to learn how to identify the substrate once you get to the EP lab. Because if you're going to do substrate ablation, you're going to burn the substrate. So you need to understand the substrate. But ideally, again, 1 and 2 go together. The VT has to fit the substrate. Now this is a case, 61-year-old patient, non-ischemic, EF35, no CAD, and you can see here clearly the substrate. The substrate of this arrhythmia is an area on the lateral aspect of the left ventricle, basal to the anterolateral papillary muscle. In echo, it's thin, it doesn't move, it doesn't thicken, it's white. This is a scar. And this VT, right bundle, some transition, superior axis, could fit this scar. So now we kind of have a hypothesis, and we go and do an endocardial map, and we find a small area of a scar. Late potentials, it looks good, decent pace map, why not? We could ablate this area and see what happens. So substrate definition in non-ischemic cardiomyopathy is very useful with MRI, but the bottom line here, and Rod showed this, and I don't want to go into detail, my message here is that you can prepare for the substrate before you get to the lab. Classically, you have either RV cardiomyopathy or LV cardiomyopathy, and the LV cardiomyopathy, you either have an anteroseptal intramural substrate in which you will not have an epicardial axis because it's all intramural, or you have inferolateral scars in which epicardial axis is going to be useful. And what we also know for many years is that the substrate on non-ischemic cardiomyopathy and in some patients with ischemic cardiomyopathy is bigger in the epicardium than the endocardium. So we need to prepare for this because these are the patients that we're going to do epi ablations. Now, I love intracardiac echo. I think every procedure should use intracardiac echo because I can obtain the same information. This is a patient with a lateral scar on this series of patients that we published when Dr. Bala was with us at Penn. And if you have an echo, echogenic appearance with wall motion abnormalities, you can define the substrate. And you can see the white line here is subepicardial. You have a normal endocardial bipolar map. This is a patient that I know I'm going to have to go epicardial even before I start. And when we go epicardial, in the same area of the echo finding, you find all these late potentials. So echo is also very useful. So when we fail endocardially, then what happened? Why would this go on? And this is beautiful. This is the first approach for epicardial aspect that goes to the group in Sao Paulo with Dr. Sosa, Dr. Scanavaca, Andrea, Falvio, and it's published in 1996. This is the first ever demonstration of epicardial substrate in the EP lab for Chagas disease. Now, I want you to read the editorial on this paper. And this is why we struggle now, and basically, it's the story of many things in EP. This is the editorial comment of something that we could not live without today to treat patients with VT, which is epicardial mapping. In 1996, pericardial space exploration for epicardial mapping of VT, it's unlikely to have a significant clinical impact. So, I mean, this is amazing for Latin America. This is why this conference should continue. This is why Lahrs should continue, because this is the great work that is done in our countries, and it has changed the practice of medicine in our specialty. So in this patient, we ablate the endocardium. We do, you know, our little scar isolation, core isolation. We could have done substrate modification. We can ablate, whatever technique you want to use. But we didn't stop there. We tried to induce VT again. And I think it's important because now you change the VT. Now this VT is completely different. However, it has the same flavor. It's coming from a similar area, and you prove if that catheter is still in the endocardium, that the endocardial activity has been dissociated from the VT. So you can keep burning the endocardium as much as you want. It's not going to work, because this VT has nothing to do with this scar. You can see here the dissociated activity inside of that scar. So you go back to that graph that I showed you from Wendy Su. You isolated the layer in the endocardium. You're left with the intramural and with the epi. So we then go to the epi. How do we go to the epi? I am skipping this because you're going to get a master lecture on how to safely approach the epicardium in less than 5 minutes by my colleague Jorge. But you need to learn, as a point number 3, if you're going to do VT ablation and you're going to be serious about this, how to safely access the epicardium. And I'm not going to talk about it because he's going to do a tremendous job at that. So we go in this patient to the epi, and no surprise, we have a bigger epicardial scar. We have VT, mid-diastolic, nice activation. You ablate, patient is not inducible. This applies for other substrates. This is non-ischemic cardiomyopathy of hypertrophic apical aneurysms, in which the epicardial substrate is bigger. You have to think about it, but no surprise. You knew from the beginning of the case this was going to happen. This is Chagas disease, courtesy of Luis, in which you have apical aneurysm. No surprise, much bigger scar on the epicardium. This is a tool that's necessary. So we move on. So it's all epicardial. So we're done. It's going to be 100%. No, it's not, because the story doesn't end there, and you need to keep recognizing these EKG patterns. This is a patient with PVCs and VT of multiple morphologies, all of them around the septum. And when you look at this and you induce VTs of this flavor, left bundle inferior axis, left bundle late transition, left bundle faster VT, superior axis, you're dealing with mid-septal intramural substrate. You need to learn how to define this substrate, because this is the other side that doesn't have epicardial. So one message I want to give you, that not everything ends on epicardial ablation. You have to know the VT and the substrate. These are all the different ways you have to define substrate. And if you define this intramural substrate in the septum, unipolar, bipolar mapping, transseptal conduction, and lately we use the recordings from intraseptal branches to look for late potentials. This is true intramural substrate. So now we talk about endocardial extensively. We talk a little bit about epicardial. We have a third layer. It's called the intramural space. And how do we map that? We map that using the veins. Just like Luis showed for left ventricular summit VT, we use that for intraseptal VT. This is a patient here that has a clear scar on the MRI. We place these recording catheters in the septum. They're sitting on the septum, and you see here clear late potentials. This is definition of intramural septal substrate. And that's important because that's going to be useful for your VT mapping. This is entrainment from inside of the septum, great physiology. So, fourth point, not all is endo or epi. You need to learn how to define the substrate, and you need to learn how to look for intramural substrate. And sometimes you're going to have to burn purple areas because sometimes your endocardium and your epicardium are normal and your VT substrate lays right on the middle. And the only way to get there is to suspect it very highly by some imaging and some mapping, and you're going to have to burn what seems to be normal tissue. But you know it's not normal tissue because in this echo, this area was not moving. So the size matters because when you have VTs, you not always have a big scar. This is a patient with a VT that has all the flavors for an epicardial VT, normal endo, uni, and bipolar. And when we look indirectly from mapping in the septal veins, it seems early in the lateral branch of the CS, it looks early in the epicardium by indirect mapping. But what is the size of the scar? Well, the size of the scar in this particular patient was very, very small. Normal MRI, normal echo, VT. You can have a tiny scar and have very fast VT. So how do you get to this? You need to explore, you need to find, because ultimately I think this is the gold standard to define a scar. It's going to be our recordings. So you need to learn how to identify small substrate beyond voltage mapping. So you need to learn Rod's technique of island mapping, and you need to learn how to use multiple electrodes mapping. This was our last time we did a live case for LAHRS in 2019. This is a 24-year-old man with recurrent VT, normal heart, third procedure, and this is the VT. Again, definition of the clinical VT by 12-lead EKG. We cannot forget this. This is very important. And endo, look normal if you only use voltage, but if you use functional mapping, using high-definition catheters, in this case the HD grid, you can see that what seems to be normal voltage is not normal physiology. And this was a beautiful case we did here as a live case, and you can see the island map, you see the abnormal signals on this area, and we will prove it to you that when we induce VT, this was it. Normal voltage, normal MRI, normal everything. This was live case, one burn, Latin HRS 2019. It was beautiful. And I think some induction, it's important because no induction doesn't mean anything. But if at the end of a procedure or the day after a procedure you still induce the clinical VT, that patient is going to go home and have VT. So of course, if you're not inducible, it doesn't mean anything. It might be anesthesia, it might mean whatever. But if you induce the clinical VT immediately post-procedure, this is 100% recurrence rate. So I think it's very important to assess some sort of inducibility. You don't have to go crazy, but you need to do something because you need to recognize why you fail, and you need to face it, and you need to stop doing the same thing over and over again because it's not going to change unless you understand what's happening. If you do the same over and over, it won't change the outcomes. So here's where we go, and more nice mapping. We think the tools we have today are great, but maybe we're not using them at the full potential. So if you use island mapping, you use high definition mapping, and then you use the eyes the way it should be used. This is a patient with septal VT in which instead of me putting the eyes on the right ventricle, I put it on the left ventricle. And you can see a whole new era of how the structures look on the septum. You can see this septum now reversed. The eyes is in the left ventricle, you see this, and now you try to ablate. Why do we fail? I said, Fermi, why do we fail in this? Well, we fail because we're not touching the tissue. And you think this catheter is doing what's supposed to do because you get a red dot, what doesn't mean anything. In order for you to get a good lesion, you have to be in contact. This is not in contact. It doesn't matter if you say 10 grams, look at intracardiac echo. This is ablation on, the catheter is just flipping around on the septum. You'll never did a lesion, even though you got 10 red dots by your carto person or your St. Jude person. So you have to fight the anatomy, you have to look, and you have to fight that this catheter is in perfect contact for enough time with good stability to create a lesion. And this takes work, and this takes attention to detail, and sometimes you have to go to the other side to do the right thing. And I said, Rod said this, prepare for the case. We use Payne's D-score, and you need to prepare before you go in the case to do this, not only with imaging, with the definition of the VT, but with the risk of the procedure. So fundamentally different types of VT, fundamentally different approach, but they all share the same thing. You need to understand anatomy, and you need to understand the EKG. These are non-ischemic or complex procedures. Epicardial substrate always greater in the epi than the endo for non-ischemic, and for some patients with ischemic, and you have to suspect substrate, use EKG and imaging. The challenges, of course, not tolerated VT, small epicardial substrates, the progression of the disease and the substrate and the genetic mutations like Titan and others are very, very difficult, and our biggest enemy is thick myocardium and very thick fibrotic scars because we simply yet don't have the perfect tools to ablate. So hopefully there's some light for us in the future, and thank you very much.
Thank you very much, Dr. Fermin Garcia. It was a wonderful lecture, as always. Thank you. So our next speaker, Jorge Romero. Welcome. Jorge is an EP cardiologist. He is in the Brigham and Women's Hospital at Boston, Massachusetts. Welcome, Jorge. It's a pleasure to have you here.
Thank you. Good afternoon. I want to thank the Latin American Heart Rhythm Society for this kind invitation. It's a pleasure to be here. And today I'm going to be presenting what's new in epicardial access. I'm going to discuss a little bit about CO2 insufflation. We're going to describe the safer epicardial approach that we presented early in HRS this year. And I'm going to give you like a glance of more sophisticated devices that are being manufactured by industry. However, most of these devices are not commercially available, so for now, you should be very interested in this talk to learn how to get epicardial access in a safe and efficient manner. So just to give you a little bit of background, Francisco Romero was the first cardiothoracic surgeon. We don't have the slides now. The first cardiothoracic surgeon to explore the epicardial space by open thoracostomy. However, that was considered like very aggressive, and the procedure was abandoned for 40 years. Then this physician from France, Dr. Shaw, he did the first blind pericardiocentesis using English trocar in the 3rd and 4th intercostal space with a lot of complications as well. And so it was abandoned now for 1 century, the exploration of the epicardial access. And in 1978, we have the first report of subxiphoid pericardiocentesis in patients with moderate or severe pericardial effusions, 2 or 3 centimeters. The success rate wasn't that great, and the rate of severe complications was 21%. Of course, now we do pericardiocentesis in a much safer way, but still not a benign procedure. In 1996, like Fermin mentioned, Dr. Escanavaca, Sosa, and De Avila, they published this seminal work in Chagas patients, and this has a tremendous impact in Latin America, mostly because of the migration patterns. In Latin America and Mexico, Chagas is endemic, and now we have it in the US, Canada, several countries in Europe and Australia. And the same group, Escanavaca and Cristiano Pisani, they published the first and only randomized control trial, a small trial comparing endo-epi versus endo in Chagas patients. And as you can see, they found a 40% absolute reduction in VT recurrence. Of course, they couldn't demonstrate VT mortality reduction because all the patients that fail endocardial ablation, they cross over to the endo-epi. with Dr. Natale and Rod, we published this meta-analysis comparing almost like 22 studies of endo-epi versus endocardial ablation. And we show, as Rod mentioned, in EP, it's very difficult to show a benefit on all-cause mortality. And as you can see here, if you do endo-epi ablation, you're going to decrease all-cause mortality. However, why nobody does epicardial? Because even though this is not a significant difference, it's almost 4 times the risk of having acute severe complications when you go into the epicardial space. And this is very important. Dr. Natale mentioned, we know that for Brugada, ARVD, Chagas, sarcoidosis, we have to explore the epicardium most of the time. But also in ischemic cardiomyopathy, we have a 20% absolute reduction if we map and ablate the epicardium, because many of these patients have transmural scar. So putting aside all the potential complications for epicardial access, most people only worry about severe pericardial bleeding and cardiac perforations. So severe pericardial bleeding is defined by more than 80 cc's of blood. And we have rates of these complications that fluctuate from 2.6 to 8.9, and this is using a 2E needle, micropuncture, needle-in-needle technique, and even fancier needles that have sensors to measure the pressure. And we have to understand 3 points, like 10%, 9% of these patients, they have severe pericardial bleeding, and 10 to 20% of those patients, they're gonna go for open heart surgery. Once you the epicardial bleeding and you have bleeding, most of the time you have to abort the procedure, and if you don't abort the procedure, then you cannot anticoagulate the patient to do endocardial ablation that many of those patients are going to require. Just to start giving you like ideas how to explore this space, with Dr. Natalia and Luigi, we published a paper a few years ago using the epi access needle. And this is a needle that has embedded a pressure sensor here. And you can see that it shows you the pressure, of course. And so when you're advancing the needle through the mediastinum, you don't have any pressure. Then you're going to have a transition signal. That means that you're touching the pericardium, the parietal layer of the pericardium. And then once you inside the epicardial space, you're going to have a frequency and pressure that oscillates from 5 to -5 millimeters of mercury. And the most important thing is, like, once that pressure goes to 20, 25, that means that you're touching the right ventricular wall or that you have already perforated the right ventricle. In this study, it was only 20 patients with one RV perforation with severe pericardial bleeding. And the needle costs probably $1,000 now, but it's not widely used. Also now the CO2 insufflation 3-4 years ago, we were very excited, but I know Rod loves it, but I know that many people don't use this because it has some caveats. We know that we have to cannulate the CS. Sometimes it takes time. We have to find the perfect vein to perforate. We need specialized equipment, microcatheters, wires, that increases the cost of the procedure. And if we are not careful insufflating CO2, or if we insufflate CO2 too fast, we can put the patient in tamponade physiology and we can have troubles. Also, if the patient goes into VT or VF during the insufflation, it's going to be a little bit more difficult to defibrillate the patients. And also, since we're violating the anatomy of these veins, we're perforating every single patient, the rate of severe pericardial bleeding in the largest report of CO2 insufflation was almost 5%, more than 80 cc's. No one went to the OR, but they did have to cancel the cases for severe bleeding. And also at the Brigham, for example, 30 to 35% of all patients that are going VT ablations, they have CS leads. Even though it's not a complete contraindication, it's a relative contraindication because you don't want to dislodge these leads, and sometimes the CS leads dislodge very easily. Also, sometimes people spend 30, 40, 50 minutes, sometimes even longer, because when you're trying to perforate the vein, the wire doesn't go, it goes intramural. So you have to be really careful so you don't have an intramural hematoma or dissection. But of course, if you're willing to take the time and the patient doesn't have CS leads, probably it's a very good way to get epicardial access. So this is the safer epicardial approach. It's a novel but very simple technique. It has three components. So the first component is to put the patient in apnea at the end of expiration. I know, for example, the UPenn group, they use apnea at the end of inspiration because most of the time they take a posterior access. So all the 105 patients that we included in this series, we always obtain anterior epicardial access that we believe is much safer than going through the posterior wall of the right ventricle. Also, we do it at the end of expiration because even though the distance of the needle from the skin incision to the pericardium is longer, it's going to be easier for you to compress the abdomen because the intra-abdominal pressure is lower. And of course, we always do a right ventriculography in AP and left lateral views. And I'm going to explain this in more detail in a few slides. So do you need pre-procedural imaging? You don't need it, but it's always ideal, first of all, to understand the substrate, because more than getting access, imagine when you get access, you haven't even started the case. So you do need, most of the time, to do CT, MRIs to get the substrate. So, and three important points is, one, many patients, you're going to be dealing with pericardial fat, okay? So sometimes they have 12, 14 millimeters of pericardial fat. Not that it's going to be impossible to get epicardial access, but it's going to be like more challenging. And if you're prepared, you know that you're going to be facing that fat. And this is the problem that all the devices that are being manufactured are going to have in the future, because when they vacuum the parietal layer of the pericardium, it's going to be very difficult to suction the pericardial fat, and probably you're not going to be able to get epicardial access with those devices. Also, it's important to know the location of the heart in the thoracic cavity. Most of the time you have this right ventricle in the AP projection, and the most anterior structure is your RV, but sometimes the hearts are rotated rightward, so sometimes you're going to be, if you're pointing to the left shoulder, you can lacerate the LAD or the anterior interventricular vein, even the left ventricle or the lung. So it's important to know. And in left lateral, sometimes the left ventricle is going to be the most anterior structure. So that's why it's important to do right ventriculogram. Also, if you're going to go for an anterior approach, most books, when you read, I used to read Roth's book chapter in Wang's catheter ablation book. And if you put your incision, you see the subcutaneous tissue, for example, of this patient, okay? So if you make your incision here, it's going to be very difficult for you to go in the anterior mediastinum to get anterior epicardial access, okay? So what we do is we plan our angle to penetrate anterior, and we're going to have to do the incision on the skin much lower than the Lahrs space. How do you do it? Of course, if you have a chest and abdomen CT, you can just measure the distance that you're going to use. But most of the time, you only have a chest MRI or chest CT. So you can measure the ideal side to the skin here, and using digital protractors, you can actually measure that angle. And using a single tangent formula for a right triangle, you can calculate, if you calculate the tangent of that angle and you have already your adjacent side, you're going to have the opposite side here. And that's going to give you the distance where you have to make the nick on the skin. Roth, in his book chapter, he always recommends, I don't know if you're still doing it, but he always recommends RAO, LAO, but I think it's so much easier for the inexperienced operator to do epicardial access using AP and left lateral view, because you're putting the needle in the AP projection. So apnea, we know that some patients, or most patients, the diaphragmatic excursion is from 1.5 to 3 centimeters. So if you imagine this needle here with a patient breathing or being ventilated, most of the time you're going to go through the RV. Sometimes you don't have bleeding, but most of the time you're going to go through the RV because it's a massive movement. So it's very important to put the patient in apnea. So for our right ventriculography, we do it AP lateral. We put a 5 French pigtail catheter. This is how we see it here. And as I mentioned before, we need to know the in this border is going to be the LAD and anterior interventricular vein, the left ventricle. So that's how you're going to calculate your coronal angle to avoid pneumothorax or lacerating the left ventricle or these vessels. And in the left lateral projection, even though you think that you can see the border with high quality fluoro with cine, you don't, okay? You have 5 different shadows that I'm gonna show you in the next slide. So here you can see sometimes you can go this leftward, but sometimes we have go rightward to aim in the middle of the right ventricle. And in the left lateral projection, you're gonna have 5 shadows, okay? One is the right ventricle, 2 the left ventricle, epicardial fat, pericardial fat, and both lungs, okay? So having the RB gram is gonna give you a lot of advantages, as I'm gonna show you in 1 minute. So in AP, once you do your RB gram in AP, you put a 7 French sheath, you mark it on the skin of the patient, so you don't have to look at AP anymore, and you focus on left lateral. You have your angle, very important, so when you're setting up the fluoro machine, you don't want to see the whole heart, you don't need to see the atria or the aorta, you just need to see the anterior and inferior border of the right ventricle, but more importantly, you need to see the sternum, okay, anterior and the side foot process, okay, because you need to see the needle going in. If you're only seeing the heart, you might be on top of the sternum very frequently on obese patients, or too deep, and you can damage intra-abdominal organs. The pressure, we mentioned, where to perforate the RB anterior wall. We always use it in the inferior or the lower third of the right ventricle. Why? Because most of the time that ventricle is protected by epicardial fat. Don't do it in the middle third, because that's the only portion of the heart that is totally unprotected. So once you put the patient, it's so much easier if you have biplane, so 1 shot, 1 RB gram, and we delineate the RB silhouette in diastole, so to avoid too much tenting when you're with the needle. And of course, always try to use an erasable marker so people don't hate you in the lab. It's important to know, they're gonna ask you how many cc's, for how long, how much pressure. We always, in all these patients, we use 50 cc's of contrast in 2 seconds, and we use a pressure of 750 PSI. And this is how we do it. We put the patient in apnea, we start. So all this trajectory, you can advance the needle very fast, because, assuming that you trust your anesthesiologist and he's gonna give you apnea at the end of expiration when you do the RB gram and when you're going with the needle. Always use dilated contrast so you don't obscure the field, because the moment that you don't see the tip of the needle, you can cause a lot of damage. And always try to avoid massive tenting, because you can go through the pericardium and through the myocardium. So rotate the needle and just advance your wire, and you're gonna be okay. And then you see the wire going there. Always pericardiogram, just to make sure you don't have massive adhesions. And of course, look the wire in LEO, just to make sure that you're wrapping all 4 chambers. So these were the results of that study. The median apnea time was 2.25 minutes. We know that in a regular patient, healthy patients, you can put someone in apnea for 8 minutes, cardiac patients 5 minutes. And if you have morbidly obese patients, they have really compromised residual functional capacity, and you can only do 3 minutes, but you can split the apnea, all the abdominal trajectory and mediastinum, and ventilate, and then put the patient in apnea when you're gonna perforate the pericardium. We only have 1 complication. We lacerate an inferior epigastric artery, didn't require surgical intervention, and the epicardial time was 7 minutes from the minute that we did the incision. We gotta put the pigtail catheter to the minute that we were in the pericardial space. Sometimes it took us 25 minutes, because we did it at the first cases, it was very problematic to set up the power injector. We were 100% success rate. 2 cases, we had pericardial adhesions, but we were in the pockets of the pericardium. We have 0 RB perforations, no surgical interventions, and no effusions. And of course, comparing with CO2 or micropuncture needle technique, no surgical interventions, but it's better than CO2 for epicardial bleeding, severe epicardial bleeding, and of course, with needle, they have 9% severe bleeding.
Thank you very much, Jorge. And unfortunately, we are running late of time, and we don't have time for questions. Thank you very much for the great lectures for the speakers, and thank you for your company here in the sessions. And still, I hope you can enjoy more of the HRS 2023. Thank you very much all, and see you soon.